real pleasure to be here, and I'm not sure if you guys have had a chance to take a look at some of the special rooms in the building, but it's my first time here at the Royal College of Physicians, and it's quite interesting to look back at where we've been from and now look forward to where we're going. And my talk really is going to spend a lot of focus on this concept of prediabetes, whether it is a true clinical construct, where will it lead us in terms of additional therapies that we may or may not institute as this becomes more and more prevalent. So here are my disclosures. And here are my disclaimers. So I'll tell you that I am a cardiologist, I am an epidemiologist, a clinical trialist, so I'll give you my viewpoint. I'm not an expert in diabetes, I'm not an expert in prediabetes, but I think you'll benefit from an external take on this from what I know of the simple basis of disease etiology and how we measure things. I'm an American, so you're going to get an American perspective, but I also think that's okay because we're responsible for this concept of prediabetes, and now you've joined the party and you're going to have to hang out with us and figure out what to do with it. And certainly my opinions may differ from many in this room, so I welcome some engagement from all of you as you've had to grapple with this condition as we are screening more and more patients who are now labeled with prediabetes. Okay, so the talk title I was given was Prediabetes and I inserted cardiovascular because there's so many other putative results of prediabetes. Does the cardiovascular damage, has it already commenced or is it too late? The topics we'll discuss will consider the origins of prediabetes as a clinical construct. It's relatively new, as many of you know. We'll review the diagnostic criteria for prediabetes and the data regarding some of the overlap of these diagnostic criteria. Where do they converge and where they're discordant? We'll consider whether cardiovascular damage as measured by clinical markers, things like echo, MRI, et cetera, whether that's distinct from the convergence of risk factors, just because this condition is associated with many other risk factors for cardiovascular disease. And we'll consider whether the cardiovascular damage as measured by cardiovascular events, as you follow these patients over time, can it be reduced if we remove the exposure, prediabetes, through diabetes prevention trials? And that's a bit of a stretch. We'll see how that might play out. I'm just giving you as much evidence as can be gleaned from the existing data. And as a result of these considerations, the next step, are we on this cusp where we're considering using strategies for aggressive cardiovascular risk reduction that we've imposed on the condition of diabetes? Are we starting to think about whether they should be extended to patients with prediabetes? Are we there yet in terms of providing that therapy, extending that therapy to millions and millions, if not a billion patients worldwide? So I think it's worth it to look at the timeline where this term began. I think in the lower left, you can see that it's relatively new. Just about 20 years ago, the American Diabetes Association begins to call elevated blood sugars that are not in the pre-diabetic range, gave this term prediabetes. Now, I'll insert that because of the obesity epidemic in the US, perhaps not as bad as what's going on in this parts of the world, there was a lot of energy and emphasis on trying to get patients with obesity to manage it better, to reverse the subsequent cardiovascular risk, to pay more attention, and thus this gave sprout to the idea of prediabetes. In 2003, prediabetes was first mentioned in the ADA Bible for treatment, the treatment standards. In 2004, the ADA lowered the glucose criterion to 100 for fasting plasma glucose in milligram per deciliter from 110. In 2005, another very important respected organization in the US, the Centers for Disease Control, adopts that. And you can see that the increase in prediabetes is punctuated by the changes in the definition and the moving of the goalposts back. In 2010, probably when things really changed for many of you, hemoglobin A1C was now included as a criterion, an elevated A1C. The CDC then adopts that, and you see the dramatic increase in prediabetes, vastly outstripping patients with diabetes. And really, I have to tell you, looking at the epidemiologic data, I cannot tell you with one number, with one certainty, what the risk of conversion is from prediabetes to diabetes. Some studies say that your risk of being prediabetes is about 2% per year. Others tell you you have about a 90% lifetime risk of developing diabetes. So it's really not clear, and I think it depends on the patient that you're seeing in front of you. There are other risk factors, and also importantly on the diagnostic criterion that was used to give that label. So in the end, what's happened, in addition, I should mention, well, let's talk about this first. Prediabetes is now the second most common chronic condition in the US after obesity. And there has been some concern that this may relate to also some conflict in terms of expanding medical therapy to this group. So I want to go through some of the pros and cons of this as well. All right. So in terms of using the label, there have certainly been advocates on both sides. On the left hand are some of the pros, heightened awareness of the condition and its potential risk for both diabetes and cardiovascular disease. The observation that some individuals with prediabetes already manifest microvascular complications, in particular retinopathy and renal disease. Meta-analyses of large cohort studies that have showed an increased cardiovascular risk associated with prediabetes. And then certainly it does facilitate conversations you have in the clinic about risk factor management, about diet, about lifestyle intervention. So helpful perhaps in day-to-day communications with your patients. In terms of cons, certainly diabetes prevention trials showing what we can do to prevent diabetes were all conducted in patients who had enrolled on the basis of impaired glucose tolerance, not on the A1C that we are commonly using in clinical practice today. So do they apply? Do the things that we tell our patients, this will prevent diabetes, do they really apply to patients who have an elevated A1C? In the US, we do concerned that many of these patients will never develop the condition. And we can adversely affect patient self-image. That's certainly a concern. Many health care providers get that feedback from their patients. And then, of course, the healthcare costs and the drug side effects, should we start expanding therapies to this large pool of patients. So let me remind you of the diagnostic criteria, and it differs by guiding body. On the top of this slide are shown the American Diabetes Association criteria, and there are 3 metrics, parameters that can be used. Impaired fasting glucose, a value of 100 to 125 or 5.6 to 6.9 millimolar. IGT, 140 to 199 at the 2-hour mark. Here are the millimolar values. Hemoglobin A1C, 5.7 to 6.4% millimolar values. And then for the IEC, just the hemoglobin A1C test, for the World Health Organization, both IFG and IGT, but importantly in absence of A1C recommended by that organization. You can also see from the slide that the American Diabetes has lower thresholds for fasting plasma glucose and has lower thresholds for hemoglobin A1C. So what does that do to the type of patients that are being diagnosed? So let me give you one example of this, recently published in 2022. This is from a European cohort, the CORA study conducted between 1999 and 2014. All patients had each of the blood tests shown here, impaired the 1 hour, the fasting glucose, the glucose tolerance test, and the A1C performed. They limited it to patients, the 5,000 or so, without diabetes, and they used the ADA threshold, so a little bit more aggressive. What they found is 50%, 1 in 2 patients in this population without known diabetes met at least one of the criteria. Now, if you look at that group, half of the population who met at least one criteria, impaired fasting glucose was present in 66%. So the remaining 33, 34% would not have IFG if that's your practice in your clinic. 50% would be detected by A1C, but the remaining 50% would not if you apply A1C as your preferred criterion in your clinic. And for IGT, picking up only 32% of those patients. So if you're using routine glucose tolerance, you will not pick up the remaining 70% or so if that is the only strategy that you use. The other thing that was important in this study, I thought was very important to recognize, is there may be sex differences. If the IFG, fasting glucose, is more likely to be elevated in men than in women. So you will call more individuals pre-diabetic if you use that criterion. And for the A1C, there are more women who tend to have a high A1C than there are men. So the criterion matters, and they're somewhat discordant. And if awareness matters, that's the reason that we're doing this, is to trigger changes in behavior, perhaps delivering more resources to these individuals with prediabetes. I think we have to ask the question, should we be worried about dissimilar rates or bias in the diagnosis by sex, by race, by ethnic group? There are differences. I don't have time to go through all of those for race and ethnicity, but certainly there are differences there as well. So what about cardiovascular disease? That certainly is one of the main reasons that we consider risk. In patients with prediabetes, you know that there's a confluence of risk factors. And that was shown very nicely in this study here, just if you want to get some numbers. This was a US cohort over 5,200 patients, defined again by the ADA thresholds of prediabetes. Population was separated according in dark blue, those with diagnosed diabetes, pre-diabetes, I should say light blue, dark blue, and then the gray, normal glucose. In terms of the prevalence of hypertension, patients with pre-diabetes had a very high 36% prevalence of hypertension. That was intermediate for these three groups. Over half had dyslipidemia. A small proportion, 1 in 10, had evidence of CKD by any biomarker assessment. But importantly, the mean BMI was 30%. BMI tends to be a normally distributed factor, so that's half over 30 and half below 30. So really important in terms of what goes along with prediabetes, and you can start imagining what's the next question. How can you distinguish the effects of prediabetes on cardiovascular disease from the company that it keeps? So is it causal or is it convergent? It just happens to be a condition where all these risk factors aggregate, and from Dr. Dupre's talk this morning, you know that central obesity might be one of the defining central roles and a causal factor for all of these. What I've tried to do here on this slide is separate out those factors in the green that tend to go along or more directly linked to dysglycemia and insulin resistance, and then those that are maybe coincidental on the right-hand side. And there has been a lot of work. There has been a lot of work to look at the direct impact on mild to moderate levels of hyperglycemia on vascular risk factors, intermediate, that could cause cardiovascular disease. So we have suggestion from experimental studies, from clinical translation studies, that mild to moderate hyperglycemia can impact oxidative stress, can impact inflammation, and which can consequently cause macrovascular disease. But in a living human system and in our patients, prediabetes comes along with all these other factors that may not be caused by prediabetes, but are just coincident. So we really have to think about that as we consider, is it truly a target of therapy? What about clinical markers? So I'm an echocardiographer, so I do look at echocardiograms quite a bit. And there have been several studies starting with echo, but then going on to cardiac MRI, looking at markers of LV strain, which you may have heard of for diastolic function, just measuring cardiac troponin T levels in pre-diabetic patients without, or those without diabetes, and then even looking at coronary artery calcium scores, all surrogate measures of damage. And what the findings show from, these are just a select few, there are many, many more. The findings show that if you look at cardiac MRI and compare patients with normal glucose tolerance to those with IFG or IGT, their left ventricular stroke volume index, LV function, is somewhat lower. Their wall thickness is somewhat greater. If you look at strain, there's lower myocardial tissue velocities, strain rate. The indices of strain are lower or worse in patients with prediabetes. And cardiac troponin, ambient levels of troponin T tend to be higher if you have patients who have an A1C of 5.7 to 6.4 versus lower normal range values. And certainly the duration of prediabetes is associated with the preponderance of coronary calcium. That's all there. But what I want to show you next is that there's substantial confounders in all of these studies. The patients with prediabetes tend to be older, they have higher BMI, higher blood pressure, they're on more vasoactive medications, dyslipidemia, et cetera. And in some of these studies, when you adjust for those factors, the associations largely attenuate, if not disappear. So again, very challenging to come up with an independent effect of prediabetes, yet many of your patients are diagnosed with this condition. All right, what about experimental data? I looked through a ton of articles to come up with some experimental evidence that I liked, that just controlled glycemia and did not impact lipids or other values. And so I liked this one. This was published in 2020. And again, in animal models, you can have more control over the exposure, over the duration of that exposure, and how long you follow the animals. And so this was a study in which mice, either on the left-hand side, ApoE double knockout mice, they are atherosclerosis prone, they're primed for atherosclerosis, or on the right, wild-type mice. What happens when you expose them to transient intermittent hyperglycemia? And that's the panel shown here, just the fasting glucose levels. I think you can see for these atherosclerosis mice, prone mice here on the left. That was done for a period of 8 weeks without any change in A1C or lipids. I hope you can see that there are these areas that light up here by oil red O that tells you about lipid deposition. If you do cross-sectional analyses compared to the saline-infused mice, you see structural abnormalities that occur in the aorta. You see lipid deposition, so increased lipid area. You see increased accumulation of macrophages, and you see increased collagen deposition. So there may be something there, and certainly this experimental evidence suggests that. If you look now at wild-type mice, so these aren't atherosclerosis prone, and you do the same sort of experiment, you infuse them 4 times a day for 1 day, look both at the 1-day time point and the 7-day time point, you can see, and this is sort of what you create, mimicking, again, what happens in a patient with prediabetes. You can see an increase both by 1 day in granulocytes and from the bone marrow that persists, and then you can see an increase also in circulating markers of inflammation. So transient intermittent hyperglycemia can be pro-inflammatory. So there is certainly a pathway here, but challenging to do this kind of study in humans. Okay, this is a very busy slide, but I wanted to show you comprehensively what the diabetes prevention studies show. On the top of the slide are the studies that have long-term follow-up. On the bottom are those that have shorter-term follow-up, really didn't participate in an observational cohort. And the question is really, does removing the exposure, controlling the development of diabetes, impact cardiovascular events in the long term, or in the short duration in which the intervention was applied? And the sample sizes are shown here, small and large studies. Importantly, all of these cohorts enrolled patients with impaired glucose tolerance. You had to have IGT, could not get in with an A1C alone. Some studies being short duration, but then both the DQP OS having 20-year and 30-year follow-up, and then 21-year follow-up for the DPP, Diabetes Prevention Program, just published a few months ago in Circulation. Many different interventions. I want you to focus. Clearly, they diminish the occurrence of diabetes, each of these types of interventions. But if you look at the development of cardiovascular events, There really is, except for this 30-year study in the DQ-PDS, you get some reduction in cardiovascular events, about a 30% actually, but that is not replicated at 20 years in the larger DPP-OS. You also get some reduction with acarbose in the STOP-DM study, but that was not replicated in the larger ACE study. So really some challenges in terms of determining that direct link between prediabetes and cardiovascular disease, even in very long-term studies where you have the opportunity to have that prevention manifest. So takeaways from this: none of these trials enrolled on the basis of A1C, so the results may not apply. And I'm telling you this because these are the prevention strategies that you may offer your patients in the clinic. So important to know this. Very effective in high-risk IGT patients, but I'm not sure what we can say about those who are included based on A1C alone. In long-term studies, the duration of the intervention was limited to the initial years of follow-up in terms of cardiovascular events. But nonetheless, the benefits on diabetes prevention persisted throughout that period of follow-up, 20 to 30 years, but you get no manifested reduction in cardiovascular disease. The lifestyle results from DQ-DPS were not replicated. The acarbose results from STOP-NIDDM were not replicated. So there's no consistent signal that diabetes prevention in patients with prediabetes reduces cardiovascular events. Okay, I'm going to close up fairly soon, but to give you some thoughts from the guidelines. So these are the most recent US and European cardiovascular prevention guidelines. I went through them and tried to figure out, was prediabetes even mentioned? In the 2018 and 2019 American guidelines, not mentioned. Metabolic syndrome was mentioned with just the elevated glucose criterion listed as a risk-enhancing factor if it comes with metabolic syndrome. Otherwise, no specific recommendations. This is important. 2019, the ESC-EASD guidelines, the European guidelines in collaboration with the diabetes organization, came up with a number of recommendations, and I think I can probably get on board with most of these. The diagnosis, use glucose testing with A1C or fasting plasma glucose on an OGTT if inconclusive. I'm not sure entirely about using A1C. Others in this audience may have more information or preferences. In patients with cardiovascular disease, assess glycemic status in all of these patients. In patients with ACS, if you're going to check a glucose test, don't do an OGTT within 4 to 5 days because of false positives. Screen for microalbuminuria, sure. You can use a transthoracic echo, coronary artery calcium, or ABI. Those can be considered in these patients to get better risk stratification. Routine testing of novel biomarkers is not necessary. I would probably agree there. In pre-diabetic patients, not really proven to have improved utility and cost effectiveness. Importantly, individuals with prediabetes are not necessarily at increased risk of cardiovascular disease. You should just risk stratify them like everyone else in the general population. Important to institute lifestyle interventions in these patients, certainly, but I'll tell you that some of my patients with prediabetes are very lean, are very small, and very Asian, sort of like me. So I'm not sure that lifestyle intervention for everyone. Again, I think you have to look at the patient and see what you're dealing with if you want to tell them to do more of what they're doing already. Smoking cessation, certainly. Risk of new onset diabetes is lower with the ACE or ARB than with the beta blockers or diuretic agents. So if you have an opportunity to choose, maybe a preferential ACE ARB. If you're going to use a beta blocker, nebivolol, which we don't use that much in the US, may have less impact on insulin resistance. Ramipril might improve reversion to normal glycemia. Statin therapy, again, there is an increase of conversion to type 2 diabetes, but in a high-risk patient who also already warrants statin therapy, go ahead and use it because the risk is outweighed by the benefit. And then the ESC guidelines on cardiovascular risk prevention 2021, I did not find anything there referring to prediabetes or referring back to the other guidelines. And you may all have more information about that. I'm going to stop there. I had one or two more slides, but I'm going to stop there. Really, maybe just with this one, is that we really have a long way to go before we start extrapolating our evidence in extant diabetes to the pre-diabetes population. GLP-1 agonists, all the things, SGLT2 inhibition, do we really want to start those in the pre-diabetic population? We don't have any evidence for that in clinical trials, but because of our motivation to reduce cardiovascular risk, that may be the direction in which some of these guidelines go. We'll have to see. I'll stop there. Thank you very much.